Good morning, good afternoon, good evening. I'm Dr. Kuan-Fu Chen from Tonga Memorial Hospital. Today, I'll guide you through how sepsis management is evolving from rigid bundles toward precision care powered by biomarkers and artificial intelligence. We will be focusing on 5 segments today. First, why the R1 bundle is being assessed. Second, how the paradigm shift in biomarker utility, such as procalcitonin and beyond. Third, how the extreme early resuscitation is now helping. Fourth, using heart rate availability monitoring and AI, how our ongoing work is helping. And lastly, is the causal machine learning and future direction. This figure just distills current sepsis management priorities. In the emergency department, our job is to recognize sepsis early and administer broad-spectrum antibiotics promptly, because every hour delay increases mortality. We then resuscitate with several liters of balanced crystalloid. Note that colloid and crystalloid are preferred, while starch and high chloride fluid are discouraged. If the patient remains hypotensive after fluid, start vasopressor within 1 to 6 hour window. Using norepinephrine as the first line, dopamine or phenylephrine are no longer recommended. Avoid outdated protocol like early go-there therapy. Today, we individualize target rather than pursuing rigid CVP numbers. Outside the ED, critical care team will handle lung protective ventilation, insulin infusion, and nutrition. We should minimize deep sedation and recognize that most molecular targeted therapy remain experimental. In short, our ED focus on prompt antibiotics, appropriate fluid, early norepinephrine if needed, and avoiding outdated and harmful practices. Those steps give you sepsis patient the best chance to survival. Let me summarize our 12-year cohort study from Taiwan's National Health Research Database, examining trend in sepsis management and outcomes. On the left, the top panel tracks adaptation of diagnostic and therapeutic tools. Although you cannot see, like lactate testing, procalcitonin measurement, and balanced crystalloid juice climbed steadily, while high chloride fluid and starch fell out of favor. The bottom panel shows that although the incidence of severe sepsis increased, the 28-day hospital mortality dropped from 21% to 15% as these evidence-based interventions were implemented. On the right, the forest plots displayed the result of propensity score matching. Interventions associated with reduced mortality including procalcitonin testing, lactate measurement, PEG red blood cell transfusion, albumin infusion, balanced crystalloid, and dopamine. For ED clinician, the takeaway is clear. Make sure to obtain lactate promptly, consider procalcitonin to guide antibiotics, resuscitate with balanced crystalloid, and use blood or albumin transfusion judiciously. These steps, when combined with timely antibiotics and appropriate vasopressor support, can meaningfully reduce sepsis mortality. Let's take a look at the original 1-hour bundle, which many of us memorized. Measure lactate and repeat if more than 2 millimole per liter, obtained blood culture, administer broad-spectrum antibiotics, give a 30 ml per kilo crystalloid bolus if patient is hypotensive, and start vasopressor to maintain MMAP more or equal to 65 milligram mercury. However, several aspects of this bundle are no longer universally recommended. We now know that inflexible 30 ml per kilogram fluid bolus can lead to volume overload in some patients. Starting vessel pressures within minutes of shock onset hasn't been shown to improve mortality, and 1 hour deadline of antibiotics may not be appropriate for all cases. We will explore these updates in the next few slides, which outlines how the Surviving Sepsis campaign has evolved its guidance, shifting from a rigid 1 hour bundle toward a risk stratified, more nuanced approach. So keep these classic steps in mind, but prepare to see which one has been refined or replaced by newer evidence. To understand why our early management bundle has changed, let's look at this timeline. From 2006 to 2016, observational studies like KMAR study in critical care medicine showed that each hour of delay in starting effective antibiotics after hypotension onset sharply increased mortality. Early bundles therefore focus on giving broad spectrum antibiotics and fluid as quickly as possible. In 2018, the Surviving Sepsis campaign merged the existing 3-hour and 6-hour bundles into a single hour 1 bundle. Urgent immediate lactate regimen, blood culture, antibiotics, and 30 ml per kilogram crystalloid bolus. The bar chart on the right illustrates the rationale. Patients who receive antibiotic microbiomes in the first hour have the highest survival fraction, and the survival declines as the delay increases. By 2021, however, the SSC acknowledged that a rigid 1 hour mandate doesn't fit every patient. The guidelines shifted to risk stratified timing. If the patient has septic shock or a high likelihood of sepsis, antibiotics should still be started with 1 hour. If sepsis is only possible, clinician can use up to 3 hours to reevaluate before starting treatment. This balances rapid treatment with diagnostic accuracy. Recent national updates like Ireland embedded this two-pathway approach and emphasized dynamic reassessment rather than a stopwatch. Early antibiotics save lives in shock, but the evidence is weaker in non-shock sepsis. Thus, defining time zero and tailoring therapy to each patient are critical. For earth-leading ED, the key takeaway is recognize shock early and treat aggressively within an hour. But the borderline cases take a moment to stabilize, evaluate, and start antibiotics within 3 hours. This risk-based strategy improves outcomes without overtreating patients. When it comes to sepsis, there's no single gold standard test. So clinicians often look at biomarkers as adjuncts to clinical judgment. The Surviving Sepsis campaign actually recommended against using procalcitonin alone to decide antibiotics timing because the evidence is low quality. Our AJM GRACE study synthesized the evidence across conditions to guide emergency physicians. In short, PCT is useful in certain scenarios, but should not be applied universally. The purple box on the left lists a few situations when PCT is recommended, namely lower respiratory tract infection, pyelonephritis with pyuria, and acute pancreatitis. While the box on the right highlights where PCT is not helpful, including COPD exacerbation, fever alone, or heart failure as a standalone sepsis test. This table breaks down the recommendation by conditions and evidence strengths. As you can see, some are with high evidence and strong recommendation, and some with just moderate evidence. So the take home for the ED is to use PCT judiciously when the patient presents with a lower respiratory tract infection or pyelonephritis with pyuria, a PCT more than 0.25 nanogram per ml supports starting antibiotics, and a low PCT encourages withholding or stopping them, but always in the context of clinical scores such as Q-SOFA or SOFA. In other conditions, especially non-septic fever or heart failure, PCT shouldn't influence our decision. Above all, biomarkers are aid, not replacement, for clinical judgment. Our recent 2025 Bayesian network meta-analysis compared dozens of biomarkers to see which can be used for sepsis detection. And we found that CD64 has the highest diagnostic accuracy for sepsis, while STREAM1 and Preseptin following behind. Importantly, these biomarkers outperform clinical scores such as Q-SOFA and SIRS. That's promising, but the guidelines caution us not to over-rely on any single markers. Rigorous validation and integration with clinical assessment are critical. On the AI front, the Sepsis Immunoscore is the first FDA-authorized software as the medical device for sepsis detection. In a multi-center cohort study, it achieved an AUC of 0.82 for sepsis diagnostic, 0.8 for in-hospital mortality, and 0.74 for ICU admission, outperforming SOFA, PCT, CRP, and SIRS score. In the ED, we should view biomarkers and AI as complementary aid rather than standalone diagnostics. CD64 and similar biomarkers, as well as tools like Immunoscore, can help us stratify risk sooner, but they should be interpreted in the context of vital sign, Q-SOFA/SOFA score, or clinical judgment. Ongoing validation and careful implementation should be the key to translating these innovations into better patient outcome. So let's revisit fluid resuscitation. How much is enough? In the 2016 Surviving Sepsis Campaign algorithm, it's recommended that 30 mg/kg crystalloid bolus for sepsis-induced hypotension were elected more or equal to 4 millimole per liter, with adjustment for patients requiring high flow oxygen or those with end-stage renal disease or congestive heart failure. As you can see, this algorithm recommended universal 30 ml per kilo crystalloid bolus for most septic shock patients. Is this volume appropriate for everyone, or could it lead to fluid overload in certain subgroup? When do we reassess after giving fluid? The algorithm lists many dynamic measurements such as blood pressure, heart rate response, urine output, cardiac ultrasound, CVP, pulse pressure variation, etc. Which of these are feasible in the ED, and how often should we reevaluate? Then the natural question follows our discussion on fluid load. When should we add pressures, and how conservative should we be with fluid? For vessel pressures, our meta-analysis of more than 6,000 patients found no survival benefits when vessel pressures are initiated in the first hour of septic shock. The bar on the left shows the odds ratio near 1. By contrast, outcome improvement pressure are starting within 1 to 3 hours, and time zero was defined as septic onset. Pressures given after 3 hours were associated with higher mortality. So for fluid resuscitation, a separate systematic review compared conservative versus liberal strategy in septic patients with congestive heart failure, CKD, or cirrhosis, and found no difference in mortality or organ failure. This reinforced the need to avoid fluid overload and assess frequently with dynamic measurement. The take-home for the ED: don't reflexively start vessel pressure within minutes of shock recognition, and don't automatically give large fluid volume. Use bedside tool to guide ongoing resuscitation. Up to this point, we've talked about when to start fluid and pressures, but one of the biggest hurdle is something as simple as defining time zero. Is time zero the moment the patient hits triage, when sepsis is first diagnosed, or when shock develops? Studies vary, and that variance skews how we interpret the timing of inotrope and fluid. Secondly, extremely early vasopressors may rob patients of the chance to respond to fluid alone. Our meta-analysis showed no mortality benefits when pressors were started in the first hour of septic shock. In fact, patients did better when vasopressors are started in 1 to 3 hour window after shock onset, once we had the chance to optimize fluid. So, what do? The best course is, again, personalized resuscitation. Use dynamic measure to assess fluid tolerance early. Those tools help identify patients who truly needs more volume versus those who should receive vasopressor sooner. Later, we will dive into specific dynamic assessment and practical algorithm to guide your bedside decision. So let's shift to how we decide whether or more fluid will actually help our patient. This table compares bedside tests to predict fluid responsiveness. A standalone or mini fluid challenge measures the patient directly responds by risk fluid overload and requires precise monitoring. The passive leg raising test mimics a fluid bolus by temporarily shifting venous blood from the legs to the central circulation. It requires no additional fluids but does require real-time cardiac output measurements and cannot be used in patients with elevated intracranial pressure. So for stroke volume variation and pulse rate variation, use heart-lung interaction in mechanically ventilated patients, avoiding fluid boluses but require controlled ventilation and low tidal volume. The inferior vena cava and superior vena cava variation and respiratory occlusion tests also rely on mechanical ventilation. They require careful ultrasound or hemodynamic monitoring and have more limitations. Each method has trade-offs. No single test is perfect, but they all can help us avoid blindly giving large bonuses. A JAMA 2016 meta-analysis quantified the diagnostic performance of these tests. The clear winner is the passive leg raising test within cardiac output monitoring. Other tests like SVV, PPV perform well only in mechanically ventilated patients and aren't as easy to deploy in the ED. In summary, use the passive leg raising test whenever feasible, monitoring cardiac output or a surrogate. However, I wonder how many of you have done that in your busy shops. So let's talk about other possibility. The heart rate variability reflects the balance between sympathetic and parasympathetic tone. When patients begin to deteriorate, HRV drops because the autonomic system becomes dysregulated. Studies have shown that alterations in HRV during the early stage of sepsis correlate with worse outcomes. Our CGMH algorithm takes advantage of this. It extracts features from continuous ECG signals and feeds them into a machine learning model that can predict shock up to 2 hours earlier than conventional vital signs. We've validated this model on our own cohort and the MIMIC public database. It is currently being tested in a physician consent randomized trial enrolling thousands of ED patients, and we're building it into a FireSmart platform for global deployment. The award image on the right is the 2025 Future Technology Award from Taiwan's National Science Council, recognizing our HRV-based shock prediction model. The pipeline along the bottom, ECG signal, feature extraction, machine learning model, alert and response, illustrate how we convert real-time physiology and actionable bedside alerts. Let's get back to the original paradigm to see what we can do for the future. Now, we focus on specific interventions, timely antibiotics, balanced fluids, early vasopressors, and dynamic reassessment. The next frontier is to harness multiple data streams and reinforcement learning to personalize those decisions. This college highlights the breadth of modality we're exploring at Chang'an University and Chang'an Memorial Hospital, including non-invasive monitoring, such as HRV sensors and mini-wave radar detection, hemodynamic changes, and patient posture without wires. Remote PPG estimate heart rate and respiratory rate via camera, useful when standard monitoring aren't available. NLP in EMR extract latent signals from free text nodes. Hybrid ECG classification uses deep learning to recognize arrhythmia in real time. Phenotyping by unsupervised learning divides patients into more homogeneous groups for targeted therapies. And then deep reinforcement learning ties it all together using an agent that learns which sequence of fluids, vasopressors, and other interventions maximize survival. Our vision is to integrate these multimodal data streams into a single decision support tool that learns and adapts to each patient. We already tested aspects of this system, like HRV monitoring in randomized trial, and will gradually layer in these other modalities. By combining bedside physiology with AI-driven algorithms, we aim to deliver the precision sepsis care in the future. Now, we've seen how multimodal sensors can give us rich data, but how do we translate it into the treatment recommendation? Remember that observational data sets are full of confounding because sicker patients tend to receive more aggressive therapy. To estimate individual treatment effects, we need causal inference technique rather than simple correlation. Our NSTC-funded project tackles these with two layers of modeling. First, variational autoencoder and foundation model like Decision Transformer and Decision Mamba learns a latent representation of each patient's trajectory, integrate vitals, labs, nursing nodes, and sensor data. These architectures provide a compressed state space on which we can reason. Next, we employ reinforcement learning algorithm to search for resuscitation policies that balance fluid and vasopressors over time. Importantly, RL methods can handle time-varying confounding and continuously adjust recommendation as new data arrive. Just to give you all a sense of how we are implementing DRL in practice. The diagram shows our pipeline within the Chang'an Research Database. On the left, we ingest continuous observations from SOFA score, hemodynamic waveforms, laboratory data, and other modalities, and feed them into an interpretable agent. The agent processes these inputs to estimate the patient's current state and select an action, how much fluid to give, whether to start or titrate a vasopressors, or to withhold further intervention. The lower left panel shows that we also use reward signal with penalties. For example, improvement in SOFA score counts as a positive reward, while hypotension or organ injury imposes a penalty. By training on thousands of real patient trajectories from CGRD, the agent learns to maximize survival and organ function. In this sense, this framework allows us to move beyond guidelines to an adaptive system that learns the best sequence of interventions for each patient. Truly personalized sepsis care. As our model matures, they will be evaluated prospectively and integrated into clinical workflow alongside the monitoring and phenotyping methods we've already discussed. To end up, we've covered lots of ground today, from the evolution of the R1 bundle to the latest in AI and causal inference. Let me leave you with these takeaways. Sepsis is shifting from rigid time bundles to adaptive, personalized therapy. Guidelines now recommended risk-stratified antibiotics timing less than 1 hour of septic shock, with high likelihood less than 3 hours otherwise, balanced fluid resuscitation with frequent reassessment, and early but not extremely early pressure initiation. Procalcitonin is still a useful tool in specific contexts, such as lower respiratory tract infection, pyelonephritis with pyuria, and acute pancreatitis, but it is not to be used alone to diagnose sepsis or decide on antibiotics. Heart rate variability monitoring and AI-based early warning systems are on the horizon, with evidence that her HRV drops before clinical deterioration and that AI can help to predict shock hours in advance. These models to promise earlier alert and less late care. Causal machine learning and reinforcement learning will enable truly precision resuscitation by estimating individual treatment effect and search for optimal fluid and vasopressor policies, all while maintaining interpretability and safety. Finally, this field is rapidly evolving. Continuous research, multi-site collaboration, and robust validation are essential to translating these innovations into practice. Your engagement as clinicians and researchers will shape the next generation of sepsis care.